I'm sorry. Kate, thanks for that. I'm going to go ahead and do a quick acknowledgement. So the entities that you see listed here should not, the information that's being presented here should not be construed as the official position or policy of the entities that are listed here. We are providing CNE and CME credit for today's session. You'll see a link provided here. You'll also see in the handout section a place that you can download the content for today's meeting. So here's a quick overview of our talking points. We will review the IHI collaborative model. We will go through some common concepts for QI collaboratives. We'll discuss some of the support that we'll be providing to our affiliate sites. And then we'll spend some time really talking about the framework and design of the weight in kilograms bundle. And then lastly, we'll finish with next steps in housekeeping. Here you'll see the IHI collaborative model, and the PRQC definitely adheres to this standard. It's the Institute for Healthcare Improvement's Breakthrough Series collaborative design. For the last year and a half, we've worked with subject matter experts to identify some key change strategies or key interventions that will improve care specifically related to weighing children in metric units, as well as preventing medication errors. During today's session, what we'll do is walk you through some of those change strategies that you will implement over the next year and a half. There will be a series of learning sessions following today's session, specifically on August 28th. We'll start doing deeper dives, looking at some of the data that's available, discussing best practices and opportunities for improvement. Some of the common concepts that you'll hear us discuss for the next year and a half will be AIM statements. You'll hear us discuss the model for improvement or PDSA cycles, quality metrics, and then there will be several tools that we'll integrate. Some of those include key driver diagrams, workflows, process maps. There will be some discussion about SWOT analyses, and then we'll use fishbone diagrams and cause and effect diagrams. We are mindful that some of our affiliate sites are brand new to quality improvement, and as such, we will be providing formal QI education for 2 champions at each affiliate site. That access will be granted to all sites that establish their data use agreements first, and so that's something that we're definitely stressing over the next month, and so we'll discuss a little bit of that in housekeeping. But what I want to do now is really discuss some of the support that we're offering related to the collaborative itself. And the first level is within those trainers. So we have identified trainers from across the country that will provide mentorship to our affiliate sites, and these individuals have expertise in pediatric emergency medicine, quality improvement, and emergency medical services for children. The second level, which I mentioned earlier, is that we're going to be providing formal QI education through the Institute for Healthcare Improvement's Open School, and we'll also be reinforcing these concepts throughout the collaborative, particularly during learning sessions and subsequent deep dives. Level 3 is that we're expecting all sites to be sharing their best practices, specifically related to their interventions, and these will occur during those webinars and learning sessions. And then our group will definitely make every effort to distribute any new content or resources that are available. Now what I'll do is pass the mic to Kate Remick, and she'll discuss the PRQC culture.
Thank you, Crystal. And for those of you who have joined our other deep dives or webinars, you know that we talk about culture a lot. And that's because it's really important in terms of achieving success. And for those of you who haven't really been part of a QI collaborative before, This is a culture that we are hoping to create across this entire group, and that's that we're all here for a common purpose, and that purpose is to make sure that children have access to high-quality emergency care, regardless of what type of institution we work at or where we're located across the U.S. We really adhere to the motto of we all teach and we all learn. So while we have trainers that are here to help provide some mentorship, they too will be learning from you, and we will be learning from each of you in terms of the challenges and struggles that we're all facing to achieve our goals, and the types of barriers that we need to overcome. And so we learn from each other by creating best practices and innovation, and by helping to support each other by brainstorming and coming up with those ideas. In order to be most effective, we really hope to share as much as we can with one another, and so transparency is really important. If we don't understand the barriers that folks might be facing, then it's really difficult to offer support or be able to help with potential interventions. And so we ask that you try to be as transparent as possible with each other within your teams. As we'll talk about later, we will not be sharing any individual performance from a given site with anybody else, not even with your trainers. That ultimately is up to you to choose to share. But we do really suggest that you at least offer up reasons why you may have not made the progress that you want to make, so that we can really help to support you. In addition, we know that not everybody is going to achieve 100% readiness by the end of this. Our goal is really just to make baby steps towards improvement. And any improvement should be celebrated and will be celebrated as success. So we're not here to shame anybody else. We're here to support each other and build each other up. And I think we'll accomplish great things together. And then the last piece is just that this is really a grassroots effort, meaning that what works for one site might not work exactly in the same way as it does for you. And your community needs and wishes, and or even your ED or hospital administration and leadership may have different goals. And so we recognize that whatever steps you do take will need to be individualized to your site. But that's really where innovation is created. And so we're here to support each other through that. Crystal, if you go to the next slide. As you all know, we talked about different levels of support, and the team meetings are really the place where you can obtain that support from your trainers and really also from other affiliate sites that are within your team. These team meetings are being planned exclusively for your individual teams, so the training site and the designated affiliate sites. We, meaning the PRQC admin team, Crystal, Diana, and myself, are not involved in planning these meetings. These are really strictly for you all as part of your team. The trainers will be scheduling them, hopefully based on the best availability for all those that are participating. Because of distances between the various sites, these may not occur in person. They may be using virtual or teleconference communications to be able to make this happen. And these are the types of things that should be discussed during these team meetings. So bundle selection, what are you going to be working on? In addition, what type of implementation plan are you developing? What are your change strategies that you've identified? How are you working with your hospital leadership or ED leadership? And how are you able to integrate some of these quality improvement tools that we'll be learning about through IHI and also during the learning sessions to help support your progress? So at this point, if you go to the next slide, Crystal, we'll go ahead and jump into the actual bundle, which is the weight and kilo bundle that we'll be discussing today. This is the last of the 4. If you've joined some of our other deep dives, you'll know that all of our bundles have a similar framework. And we'll start with an introduction. Hopefully everyone has obtained access to the bundle guidebook. But start with an introduction, some background into why we're doing this. We'll talk about our global collaborative aim statement. Please know that each of you as an individual site will be developing your own personal SMART aim. And you'll become more and more familiar with this as you get into the quality improvement education through the IHI Open Schoolhouse and the like. We'll then talk about some of the quality measures. If we're going to measure improvement, or if we're going to actually demonstrate improvement, there has to be a measurement or analytics piece. And so we'll talk about those in particular. And then we'll talk about data collection, intervention strategies, and then finally the resources that we've been able to identify for you. So at this point, I'll turn it back to Diana for just a few minutes to go through some of the considerations and to introduce our subject matter experts.
Hey, Diana, are you there? Okay, Kate, I'll take it over for her. So this intervention bundle was designed exclusively for those sites that are participating in the PRQC, and as such, this content should not be used by other sites that are not part of the collaborative or for any other purposes without the consent of the EMSC Innovation Improvement Center. We are mindful that this intervention bundle may conflict with your existing local QI efforts, and so you are encouraged to seek support from your ED and hospital leadership regarding the adoption of the proposed change strategies as standard practice for your emergency department. And Kate, since we have our subject matter experts in the panelist mode, what we'll do, I'm going to put you guys on the spot. Sue, are you still on the call?
Yes, ma'am.
Okay, how about you go ahead and introduce yourself? We're now going to spend some time introducing you to our subject matter experts.
Thanks, Crystal. And everybody, thank you for joining this call today. My name is Sue Cadwell. I'm the Assistant Vice President for Women's and Children's Services with the Clinical Services Group for the Hospital Corporation of America, or HCA.
Welcome, Sue. Now, Marianne, are you still on the call? Okay.
She may not be able to hear her well. I can go ahead and introduce. So Marianne has been a long champion of the Federal EMS for Children program and also Pediatric Readiness for Children. She was one of the co-leads for the National Pediatric Readiness Project, is now currently Medical Director for LA County EMS Agency, is also a Professor of Clinical Emergency Medicine at David Geffen School of Medicine at UCLA, and continues to work clinically in their emergency department there and has made great efforts to improve readiness on a national level. And then Geffen, would you like to introduce yourself as well?
Sure. Good morning, everybody. My name is Geffen Bush. I'm the director, clinical director for emergency services at HCA Healthcare, a position Sue used to hold before she was promoted to her current position. So she has been gracious enough to invite me to learn with her and work with all of you through this. So thank you, and look forward to speaking with you.
Great. Thank you, Geffen, and thanks to all of you subject matter experts for joining us today. Your wealth of knowledge and expertise, and we're grateful for you being here. So at this point, we just wanted to give you all some background into the weight and kilo bundle and why we're working on this. Many of you are probably very aware of the 2000 Institute of Medicine report entitled To Err is Human. We know that healthcare providers and patients have long been aware of safety issues within our healthcare system, but this report really revealed the degree of that safety issue, and that is that they estimated some 44,000 to 98,000 people die each year in U.S. hospitals due to preventable medical errors alone. A more recent study has actually cited that that number may be even higher, on the order of 150,000 or more people per year. And even a greater number suffer from morbidity related to medical error. The total indirect cost of medical errors that result in patient harm was estimated to lie between $50 and $30 billion annually in the United States alone. And so over the past 15 years, of course, patient safety has really become a key priority for health systems. Of course, the AAP, ASAP, and ENA have all tried to address this through their policies and guidance that they've been able to provide, as well as through the National Quality Forum, which we'll talk about in just a few minutes. Emergency departments in particular are one of the top 3 areas that have high medical error rates. and fairly serious consequences related to that, and that's because of the high patient census, and also because of the more critical illnesses and injuries that present to the emergency department. Dosing errors comprise more than 40% of fatal medication errors. And we know that preventable medical errors occur when essential information is unavailable at the time of prescribing, dispensing, or administering those medications. And so medical error can be defined as a failure of any planned action to be completed as intended, or the use of a wrong treatment plan. So, Crystal, if you'll go to the next slide. So in 2001, the National Quality Forum identified several environmental factors that were associated with increased risk of committing an error when providing healthcare. And some of the factors that were mentioned in this consensus statement included that multiple individuals were involved in the care of a single patient. Of course, the high acuity illness and injury, rapid healthcare decisions and or severe time constraints, high volumes of patients, unpredictable patient flow, communication barriers with patients, families, and other healthcare providers, and of course, interactions with multiple types of diagnostic and or treatment technologies. And all of these, of course, are common to the emergency department, and so it's not surprising that this is a high area for risk in terms of medical error. If you go to the next slide, Crystal. So in response to all of this, in 2006, the Institute of Medicine developed a three-part series called The Future of Emergency Care. One of those specific parts was entitled Hospital-Based Emergency Care at the Breaking Point. And during these reports, the Institute of Medicine cited that ED visits had grown by 26% between 1993 and 2003. And at the same time, the number of EDs were declining. They cited critical shortages of healthcare providers. They cited ED overcrowding. They stated that ambulances were frequently being diverted, and that all of this was associated with poor care quality and also increased risk for medical error. If you go to the next slide on one past that, sorry, one up. Thank you. In the third part of this three-part series, the Emergency Care for Children Growing Pains, the Institute of Medicine stated that there were approximately 25% of all ED visits were in fact children. And especially when it comes to children, that most of these children are seen in general EDs. And unfortunately for both general EDs and EMS agencies, most of those systems were not requiring specialized pediatric training. They cited that most EDs didn't have the full scope of pediatric equipment, medication, and supplies, and that there's a paucity of research on best practices, clinical outcomes, and then, of course, on patient safety as well. If you go to the next slide, in summation, the Institute of Medicine reported that if there was one word to describe the current state of pediatric emergency care in 2006, it's that it was uneven, meaning that there were certainly centers of excellence where children were being very well taken care of, but there were other centers that were just not ready to meet the needs of children. And so in this report, the Institute of Medicine called for categorization systems based on pediatric capabilities. They cited performance measurements for pediatric emergency care, the need for those, the need to establish lead agencies for coordination, communication, and performance measures, and really integration of children into the larger emergency care system. Shortly thereafter, the Washington Post stated the following, that emergency medical care in the United States is on the verge of collapse. As a system, it provides care of variable and often unknown quality. And quality is really why we are all here in this collaborative, and it's to better understand the quality of care we're delivering to children in our emergency departments. We talk about quality really as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes, and that they're consistent with current professional knowledge. And safety, of course, is one of the 6 Institute of Medicine domains of quality when we talk about safe, effective, patient-centered, timely, efficient, and equitable care. And so what we're focusing on in this particular intervention bundle is, in fact, pediatric patient safety. If you go to the next slide. We know that children have a number of unique risks when it comes to safety. And and those, of course, are that they require weight-based rather than standardized dosing. And because of their developmental stages, it makes it more challenging for children to, especially young children, to effectively communicate pain, and this especially presents a problem when they are unaccompanied by a parent or guardian. And that we know also that the majority of patients that come to the emergency department are in fact adults. And so this means that there is overall a limited level of experience with critically ill and injured children. And that can result in failures or delays in recognizing that critically ill child. And this is especially true for children with special healthcare needs, who may in fact be at the greatest risk for assessment errors just because of their known needs and or disabilities. If we go to the next slide, we know that children are, of course, brought to the ED for a large variety of reasons. And the vast majority of these patients are seen in general hospital EDs. Over 80%, in fact, are. Yet most of these EDs see less than 13 children a day, meaning that children still represent a relatively small percentage of the patients that present to a given ED in any given day. And because of that, the percentage or the likelihood of seeing critically ill and injured children is much lower, relatively small. And that leads to inadequate ongoing exposure to those critically ill children. And so when a critical event does come in, it means that we tend to be less prepared to deal with that. And so it's those few critical events that often stimulate the ED to ensure readiness. We know that multiple factors are associated with those increased errors. We talked about those unique pediatric characteristics, and then, of course, known gaps. So if you go to the next slide, we know that some have referred to this as the perfect storm. Perfect storm, of course, implies a convergence of two or more weather disturbances that might create a more massive storm. And this is how we really describe patient safety in the healthcare system, which is, we've just talked about these several converging clinical and healthcare system issues, what National Quality Forum cited in terms of the environmental pieces. We've talked about the unique characteristics of children. We also talked about deficiencies, and this really puts children at a very high risk for experiencing a preventable medical error. If you go to the next slide. Compared to adults, we know that there's some estimated 5% of adults that experience some kind of medication errors, but that number is much higher when it comes to children. And in a fairly recent report cited by Miller, they estimated, based on a systematic review, that some 5 to 27% of medication orders in children contain errors across the spectrum. And that spectrum is from the prescribing to transcribing to dispensing to administering and then eventually to monitoring the effectiveness of a particular medication that was given. They also estimated that there was, in fact, about 100 to 400 prescribing errors that occur per every 1,000 pediatric patients. And this is particularly troubling because pediatric errors tend to be even greater than those in adults, in that if it's just a simple misplacement of a decimal point or the failure to calculate or change from pounds to kilos, that those dosing errors can be 2 to 100 times the correct dose. Many of you probably remember the story of the Dennis Quaid twins back in 2007. That was about 10 years ago, when their premature twins received 1,000 times the dose of heparin that they were supposed to receive. And so these are sort of the degrees of errors that can occur for these patients, just because the majority of providers are so used to working with adults, they may not recognize that a dose is so far from the correct or intended dose. If you go to the next slide. It's not surprising that the more critically ill the child, the greater the risk for a medication error. Errors typically consist of either an incorrect dose of medication or administration of the incorrect medication, and errors are certainly more common during evening and or night shifts. And an incorrect weight, unfortunately, may really follow a patient through the hospital and lead to multiple medication dosing errors because they may initially have a weight written down that is actually in pounds when it meant to be in kilos, or vice versa. And so throughout the course of their hospital stay, to their discharge and outpatient prescriptions, that single incorrect weight can really carry with them so that they can be subject to multiple medication dosing errors. We do know also that 25% of those errors are really just due to confusion between pounds and kilos. And so simply having the option to weigh in either unit can be really significant in terms of contributing to those wrong weight entries. If we go to the next slide. So there are a number of recommendations for improving medication safety. Of course, one of those is to use kilogram-only weight-based dosing. This is why we are focused on that for this particular bundle. We know that standardized measurement systems throughout an institution or throughout the entire hospital can be very impactful. Often children, of course, are at risk because we use a different process when it comes to children. And so it's a process that sometimes providers may not be used to. If you were to give sort of the analogous situation in the aviation industry, you know that you don't want to pilot practicing, for example, a crash landing for the first time when you're actually going down. But safety is something that we need to be practicing every day. And so really putting in a standardized process that's practiced across the institution for both pediatric patients as well as adults will improve the safety overall. We know that also computerized physician order entry can be helpful in terms of clinical decision support, optimizing EMR to establish electronic processes that will check doses and schedules and drug interactions and allergies and those items. And then embedded templates or clinical pathway order sets can also help in terms of alerting when errors occur. If we go to the next slide. You'll see that the Joint Commission has also made recommendations around this. Specifically, they've stated that since patient weight is used to calculate most dosing, all pediatric patients should be weighed in kilograms at the time of admission, including outpatient ambulatory clinics, or at least within 4 hours if it's an emergency situation in the setting of a resuscitation. And of course, then a length-based tape might be used. We know that there are errors even with link-based tapes, and so really the recommendation is that if a scale is available and if we have time to do it, that really a scale should be used. Many institutions have developed, have used electronic weight on stretchers where you can toggle the weight directly there when a child is placed onto a bed, but that's really important for emergent dosing. And really, of course, kilograms should be the standard nomenclature for weight on all prescriptions, medical records, and staff communications. And that really comes to not just pediatrics, but adults as well. If we go to the next slide, you'll see that here is an infographic that our colleagues at NEDARC did a great job of developing, and it just really speaks to how important safety is when it comes to children. All hospitals should weigh and record children in kilograms only, and we know from the Readiness assessment that it was only approximately 1 in 2 that were weighing and recording pediatric weights in kilos only, and that as pediatric champions, you really have a significant role in that. What you'll see also on this slide is a really nice script that the Hospital Corporation of America developed, and I'm going to let Sue Cadwell, who's one of our SMEs, speak a little bit to this scripting that they developed as a pediatric patient safety initiative in their institution.
Thanks, Kate. And I should give credit where credit is due. This was actually developed in our Denver facilities, and for those facilities that use it out there, this is probably where the most common use of this is. Scripting is hard for nurses, but it's really important that you stress how important it is that you weigh a patient in metric units only, and that the only number that you associate with the weight is that metric weight. And it can really go something like this. Mom, I'm going to weigh your child now, and the number that you hear me give you is the weight. Will sound odd to you because in the hospital, we weigh in the metric system. The reason that we do this is because everything we do for your child will be based on her metric weight. That means medication dosing and everything. I'm also going to give you a card which will help you convert that number to pounds and ounces. Do not tell me what it is. I don't even want to hear the number. I don't want to take the chance of entering your child's weight into the record incorrectly and possibly cause somebody to make an error. This card is for your information only. And most parents will understand and are grateful that you're taking the extra time to take such care with such a seemingly small task when their child is admitted. Kate?
Great. Thank you so much for sharing that with us, Sue. I'm going to go ahead and turn it back to Crystal to move on to the next steps within the bundle.
Thanks, Kate. So as Kate mentioned earlier, we're going to follow the framework that you have in the PDF document that's in the control panel. And so let's start with the aim statement that by December 2019, at least 85% of our pediatric patients that are treated at sites adopting this weight measurement bundle will have their weight measured and recorded exclusively in kilograms. Here you'll see the beginning of a key driver diagram, which is literally just a QI tool that helps teams sort of display some of the improvement strategies or the changes that they're going to implement for a PDSA cycle. Here you'll see still listed our aim statement, but we have identified potential initiatives or change strategies or opportunities for improvement that each site should consider while they're implementing this bundle. And so those sort of buckets or categories include making some changes or updates to their guideline statements, infrastructure changes in the emergency department, optimizing their EMR platform, some education related to the care team as well as the families, medication ordering patterns, and then patient-family engagement. So what I'll do is spend some time walking you guys through some of those change strategies. You can definitely find more detailed information in our intervention bundle. And so what we'll do is start off with the first category of change strategies, and that's the guideline statement. We know that some sites currently have guidelines in place for the triage process, specifically about the weighing of patients. And so here are some things that you may want to consider adopting or amending your existing protocols. And it should state that weight should be recorded at every ED encounter, be it a scale or gurney that's electronic, as the preferred method over length-based tape, and that actual weight should be obtained whenever possible, and when it's not possible, weight should be estimated using a standard method in metric units. We encourage sites to ensure that length-based tapes are available for all resuscitations, and that your guideline or statement includes some family-centered care elements within your guideline. So it could be informing families prior to weighing children and medication administration about the importance of weighing kids in kilos as a method for reducing pediatric medication errors. When we discuss infrastructure changes, we mean this is specifically related to ED processes. And in this case, we are asking that sites consider utilizing a scale that only weighs pediatric patients in kilograms, or using a scale that can be locked in kilogram mode, utilizing a length-based tape and ensure that it is available and secured in the resuscitation bay, and then utilizing a single formulation for each medication. And we're going to discuss that a little bit more detail in the next couple strategies. The next piece is the EMR optimization. We are mindful that several of our sites are using electronic medical records rather than paper, and so here are some ideas and ways that you can optimize or enhance your current EMR features. It could be that the EMR alerts the care team when a weight is not recorded in the correct unit. You may also get a notification that the weight does not coincide with the patient's height and age. For resuscitation, it could be that the weight is a required entry in the patient's medical record. We are encouraging sites to use some standard weight nomograms. An example of that could be the World Health Organization's protocol. And then EMR could also calculate medication dosing automatically based on the weight that's entered in the medical record. And these strategies are just some ways to alert the care team of your best practice, which is weighing in kilograms. Now, with respect to education, we're encouraging that, and this could be part of your yearly training for staff and members of the care team, or it could be just-in-time training that you do some form of education that includes the following objectives: the proper use of length-based tape, the necessity of weighing all kids in cases of resuscitation, some safety issues, methods for measuring weight, nomograms, discussing family engagement. It could be that your care team just needs a refresher in what your standards are, or your site-specific guidelines for weighing patients. And then we encourage you to reinforce that weight should not be estimated, but measured. And then identify your training modality. So it could be that you're integrating just a really quick PowerPoint presentation in HealthStream. It could be that this is something that's discussed during nursing hours. It could be something that's discussed during staff meetings, brown bags. It's totally up to you all, but we encourage you just to keep your team apprised of any new updates that you're making to your guidelines, statements, or policies. And then just as a reminder that we always need to do knowledge reinforcement with our care team. So you may want to consider adding posters in your triage area. There might be an opportunity where the pediatric champion provides feedback to the care team following chart audits, or develop scripts or cards for the conversion weights for families to be used by the triage nurse. And we have a couple of examples of those currently in our file sharing site, as well as the intervention bundle document. Then the next piece that we want to discuss is the medication ordering patterns. And so we have a series of change strategies that we really would love for our sites to consider adopting. It really means that you'll have to take a deeper dive into the work that you're doing to look at the safety component of this bundle. And some of those change strategies include integrating a process to track the number of incidences when an incorrect dose of a medication was ordered for a patient based on their weight, tracking any high-risk conditions with common errors in prescribing and administration, and then really monitoring family engagement in medication administration. Another piece to the medication ordering sort of category is that we'd encourage sites to integrate a tool that nurses can reference to ensure that they are providing the accurate dose when it's appropriate. Consider integrating a nurse-to-nurse cross-check to ensure that the medication dosing is appropriate. So if sites have the bandwidth to do this, you may want to consider doing cross-checks if there's a high-risk patient or medication, or cross-checking during off-peak hours in the emergency department. And then you're also encouraged to work with your pharmacy team to develop some notification system in the event that a prescribed medication does not coincide with standard practice. And then lastly, we have patient and family engagement. So we are encouraging sites. You'll notice that each of our bundles have some form of patient and family engagement included with those. And we are encouraging you to include a process where families are advised of the medication and dose prior to administration. You'll see that there's a infographic that you can use, a conversion chart, something to empower families to get engaged in the process of weighing their kids. And so, Kate, I'll pass it back to you to discuss the quality measures and variables.
Great, thank you, Crystal. So those of you who have experience with quality improvement will know that when we talk about quality, we really start with structural measures and then try to move into process, and then eventually our ultimate goal, which is outcome-based measures. How does what we do really impact the care of patients in terms of their well-being, specifically morbidity and or mortality? And so within each of these bundles, we've really tried to identify both structural, process, and outcome measures for each, and so that sites can begin to work through each of those. We know that when it comes to pediatric readiness in general, these are structural measures. It's about the infrastructure in place. Process measures really speak to timeliness, equitability, and the like. And then when we get to the outcome measures, of course, adverse events or outcomes. So for this particular bundle, we have one structural measure, and that is focused on the presence of a policy that outlines standards for weighing pediatric patients in kilograms. We also have process measures, which are related to the percentage of pediatric patients presenting to the ED that are exclusively weighed in kilos. and then those who are exclusively documented in the medical record in kilos. And then the final, which is the outcome measure, which is to really start to look at medication dosing errors that can be identified based on these processes that you implement at your local emergency department. So if you go to the next slide, please, Crystal. So in terms of variables, so again, the purpose of collecting variables is so that you can actually look at your own performance and you can have talking points related to the work that you're doing, and also be able to discuss the work that you're doing with ED and or hospital leadership, so that you can really demonstrate the impact of your efforts on pediatric readiness and on quality of care that's being provided. So the first, these are really the structural pieces, which is there a weight policy that exists, and does that policy specify two things? One, that weight be measured in kilograms only, and two, that weight be recorded in kilograms only. And again, this is can be a little bit of a challenge when it comes to EMR. We'll talk about that with all the change strategies, and Crystal kind of brought that up, and we'll continue to talk about this as we go through. But what we're talking about in this particular variable is just as the policy specify that. If you go to the next slide. There are some patient-specific variables. These exist for all of them, which is, overall date of birth, so that if it's pediatric, and then when they arrived, how they arrived, and what's their triage level. And we know this is important because the more severity or the more critical the child, or especially during pediatric resuscitations, we know the greater likelihood there is for error. And so it's to be able to speak to your own personal performance related to those types of patients that come in. Then, of course, the weight that's in the medical record, was it written in pounds, kilos, or both? Was there a target medication administered? And then what was the medication given and or dose? And that's so that we can look at those outcome specific measures. So if you go to the next slide. So those are really it for the variables related to this bundle. It's pretty short. This is perhaps the most simple of the bundles that we'll be working on. Remember that in order to actually begin to engage in this whole process, you do still need to have those data use agreements established. All of the applications were signed by ED leadership and hospital administrators. So we recommend that if you're having difficulty with the data use agreements, that those individuals be recontacted to help assist. The data portal is being developed by our NEDARC colleagues. It's approaching some finalization phases, and we'll be releasing a how-to guide for data submission and the like, and how to do that and how to walk through that data portal this summer. The real benefit of participating with the data piece, of course, is not just being able to measure your own data and performance related to the work that you're doing and to develop your own personal individual talking points, but our NEDARC colleagues are also working on developing a really nice data reporting system or dashboard, where each site will be able to go on and see their own performance, but more importantly, be able to benchmark themselves against those other sites that are participating in this particular bundle, and then also to compare themselves overall. No other site will know how you're doing. It's really just for you to be able to see how you're doing, so you can speak to that when it comes to ED and hospital leadership. So at this point, I'll pass it back to Crystal to walk through some of the resources and housekeeping.
Hello, everyone. So just as a reminder, you will see a copy of today's slides, the recording, and the actual intervention bundle, along with some additional resources on our file sharing site that's listed here. If you download in the handout section of the control panel, you'll have a link, commonly used links by PRQC, and you can download that link to access the content from today's session. Administrative-wise, as Kate mentioned, we really need you all to go ahead and establish your data use agreements. You will be receiving messaging from Eddie Zamora with Utah and NEDARC fairly soon. I think he sent out a mass set of emails on yesterday, just reminding sites to complete their DUAs or begin the process. If you haven't done so already, we are encouraging you to complete your Site Visit 1 survey. If you have not completed that survey, a member of our team will be reaching out to ensure that that's completed. As Kate mentioned, we were shooting for July 1st for those DUAs to be established, but our subsequent plan is now that we will provide contact information related or registration information for those IHI modules after you've established your DUA. So that will be sent out to the pediatric champions, and we're expecting a max user of 2 users per site. And then we'll also be requesting the contact information for those data portal users. And so that's going to be something along the way. And then don't forget, September 1 is still the go live for sites to start collecting their baseline data, piloting phase, and really working with their care team to roll out the interventions. So we have formally sort of completed the 4 bundles that we set out to present to you all beginning was that early June. Now at this point, what we're going to do is host a subsequent session specifically for the disaster bundle. It will focus on implementation of that bundle, the workflows, and data submission for that. We're anticipating that we'll release those process maps on Friday, July 27th. And then we'll have that part 2 deep dive on Tuesday, July 31st. You'll actually be hearing from our subject matter experts during that call, rather than hearing from Kate, Diana, and myself. They'll be walking you through how you actually integrate it into your existing system. So we encourage you all, if you're considering rolling out the disaster bundle within the next year and a half, to join that call. And that's really all that we have for today. Don't forget to sign up for your CNE and CME credit. The link is listed here. It'll also be available on our website, and the name of today's session is Weight in Kilograms. Do we have any questions related to the content you've received today or the collaborative? You can go ahead and submit your questions through the chat function. And then Kate, Diana, Jeff, and Sue, the mic is open, so you can give some parting words if you'd like.
So thank you all for joining us today. We'll remain on here for a few more minutes, of course, if questions come up. But again, this is hopefully the most straightforward of the 4 intervention bundles, but we're excited to see who engages in this particular bundle, because it's really sort of core to pediatric quality of care. And we're just grateful for you all joining us today.
And a quick reminder, there is we are having a data use agreement office hours where you can come and ask any questions related to the DUAs immediately following today's call. It's actually, scheduled for 12:30 Central Time. What we'll do is list the contact information here. Give me 1 second. I'll get that posted on the screen. If you have any questions related to the data use agreement process or where your hospital sort of stands in its status, we'd encourage you to join that office hours. And we'll be on the line for 30 minutes. That's 12:30 to 1 o'clock Central Daylight Time. And you can come and ask any questions. So one of the questions that we just received, as for data submitted, will any of the affiliates be asked to submit pre-intervention data?
Yes, so in order to better understand where your gaps are, it's really helpful to do a baseline assessment, but it's just related to the bundle. So we will be sharing both environmental scans just to get for you to get a better sense of the processes and gaps that are currently in place. And then if you are going to be working on any of these, whichever of the 4 bundles you choose to work on first, and or if it's more than one, eventually, that we do recommend that everybody complete a baseline assessment. So in other words, if you're going to look at maybe 20 to 30 charts of patients that come in, that you'll go ahead and collect those 30 charts, see how your performance is so that you can then measure improvement. It's only through getting a baseline assessment that you can begin to see if the change that you've implemented has indeed resulted in improvement. Hopefully that answers the question.
So the next question, were environmental scans sent out, and are they still due July 31st? So we did not send out the environmental scans as promised. Our plan is to really use those data use agreements as the anchor. And so after sites establish their data use agreements, we will send you registration information for IHI. We'll request the contact information for those users at your site that should have access to the data portal. The next piece is that we will ask that you declare which intervention bundle you plan to work on, and then based on your response, we will send you an environmental scan that's tied to that bundle. So we realize that we've made a change in what our existing message was, but we assure you that we'll be sending out mass messaging to all the sites, letting them know what the new process will be. And then we'll also be reinforcing that during our next learning session, which is scheduled for August 28th, and that's for training and affiliate sites. The next question is related to the file sharing site and if someone has trouble accessing it. So one thing I'd say is that we are mindful that some of our hospitals have firewall issues. It could be that you may need to, as sort of an intermediate process, is attempt to use your laptop and sign on to your hospital's Wi-Fi network, and you should be able to log in versus it going through your regular internet through your desktop at your desk. You may need to try to download the information from your home computer, and what we can do is if you send us an email, Samantha, I'm sorry, I don't know your email address offhand, but send me your email address. And I may just have to flood your inbox with some of those documents. We are currently working on getting our website built, and so that's definitely going to be easier for you all to access materials. But in the meantime, we are sort of using this file sharing site. So I'll send that out to you all. So one of the sites has gotten their IHI information. They have had their DUA established, and they are waiting to get information from us. Diana, if you can have them to hang tight for us. We did request a list of sites that have established their DUA last week so that we could start that process. So if you give us about, I'd say 2 weeks max, and you'll be CC'd on those emails, we'll ensure that we can go ahead and get the ball rolling for them. Any other questions? All right, Kate, Diana, any other parting words? I'm going to get that DUA office hours up on the screen in a second with the contact information. So give me 1 second.
So if you all have any other questions that pop up, do feel free to reach out to us directly, and we're happy to answer those as best we can. If you are having any questions about the DUAs, please do consider joining our office hours beginning about 30 minutes from now for that. And Eddie Zamora from University of Utah will be on the line as well to help assist. And so we hope you can join us for that.
Okay, Kate, I'm going to go ahead and end today's session. Everyone, thanks for joining. We'll keep this screen up just so if folks need to do a screenshot of the contact information for the DUA office hours. And just keep in mind that that is Central Time Zone, 12:30 to 1:30. Thank you.